really warm welcome to you all. We're delighted to bring you an update on the WHO Guideline Development Process today and the latest plans for the development of implementation guidance. And a lot has happened since the last webinar update, which was over a year ago in September last year. For those of you who don't know me, I'm Phil James. I'm a Senior Technical Associate at the Emergency Nutrition Network, and I'll be facilitating the webinar today. So to lead on the update, we are joined today by Allison and Kirrily from WHO and Tram from UNICEF. And I'm sure they're known to many of you, but I'll ask them to introduce themselves before their respective sessions. And a big thank you to them all for joining us today. So before we start properly, just a few very quick points of information. This session is being delivered in English only. All the participants, we ask you to keep on mute and off video, just so we can hear the speakers clearly, but we will be using the chat box. And we're aiming for a nice long Q&A session today. So please do put your questions in the chat box. And I've got my colleagues, Tash and Eilish, who will be monitoring the chat box and sending over your questions to me to ask the panel. This session is being recorded and it will be made available online at the ENN's Global Media Hub. So our plan for today is to have about 25 minutes to half an hour of overview from Allison, Kirrily and Tram. Allison will give us an overview of the guideline update process to date, and she's been working really hard on that as part of a wider team. And she'll hand on to Kirrily, who will join up the dots for us by speaking to how the guideline update process complements several other initiatives and approaches. And Tram will give us an overview of the implementation guidance. So thank you to the three of you, and I'll hand over to you, Allison, to get us started.
Perfect. Thank you so much, Philip. And I'd also like to start by thanking ENN for hosting this webinar today. Really excited to share with you where we're at with the WHO Wasting Guideline Development Process. So I'm first just going to give an overview of the focus of the guideline. So there are 4 areas of focus here. The first being growth faltering or failure in infants below 6 months of age. So the 2013 WHO guideline did include very limited recommendations for infants under 6 months with SAM or severe acute malnutrition. The new guideline has an expanded population definition where we're focusing on infants with growth failure and faltering more broadly, which Kirrily will also touch on. The second area is on moderate wasting in infants and children 6 months and older. And currently no WHO guidelines focus on the treatment of moderate wasting. So again, this is a new area of focus for WHO. The third topic is on severe wasting and edema in infants and children 6 months and older. So this really builds on the 2013 WHO guideline, in which we're updating some of the previous recommendations and also looking at new recommendations. And lastly, the fourth area is on prevention of wasting, which is another new area for WHO guideline development around wasting in infants and children. So I'm just going to broadly give you an idea of some of the steps that we've undertaken to date for this particular guideline. In December of last year, we held a guideline development group meeting, so a GDG meeting with 25 experts who are part of the GDG. And at this meeting, we had 4 different teams present on scoping reviews that were done across the 4 different areas. Following this, we had working group meetings that included, but were not limited to GDG members to actually refine potential questions to prioritize for the guideline. We then had GDG members score and prioritize all of the questions that were on the table to be looked at for the guideline process. After that, we then further refined the questions by having GDG members score and prioritize outcomes for each of the questions. And then following that was when we were able to finally commission systematic reviews for all the questions. So we Currently have 16 quantitative systematic reviews underway that will translate into 16 recommendations at the end of the guideline process. In the first series of systematic reviews, these are effectiveness reviews, which follow your standard PICO format, which I'll discuss later on. The next set of reviews is, this type is on prognostic reviews. So essentially what this means is looking at a set of criteria that predict later health outcomes. So these reviews are being done to inform treatment decisions, which I'll also talk about later on. In addition to the quantitative reviews, we have 4 qualitative systematic reviews being done. These include one on values and preferences. So this assigns importance to the outcomes of interest. We also have 3 reviews looking at equity, acceptability, and feasibility domains. And lastly, 3 resource use and cost effectiveness reviews. So as I mentioned in the last slide, there are many different types of ongoing reviews, and all of these will be funneled into this grade evidence to decision framework, which the GDG members will use to make recommendations for each question. So for example, the quantitative reviews will show us desirable effects of interventions at the top there, and some of the qualitative reviews will cover the domains at the bottom here. In addition to this, for each of the systematic reviews, the quantitative reviews, the grade approach is used to establish the certainty of evidence. And I'm not going to go through each of these criteria, but just to give you an overview, some of the things that review teams will be looking at include how directly do the results relate to our question, as well as is the effect size actually precise? So again, this allows us to make a recommendation that it also is presented with the certainty of evidence. So I'm also just broadly going to share some of the clinical and nutrition topics that are being addressed within the effectiveness reviews. One example is routine antibiotics for infants under 6 months of age, commercial infant formula F75 or diluted F100, specially formulated foods versus other approaches for children with moderate wasting, and then some more maternal focused interventions, one being the management of difficulties with breastfeeding. And I'm really going to show you some of the details here just to illustrate the complexity of some of the questions, even though they might follow the standard PICO format. So for this particular question, the population of interest is mothers and caregivers of infants under 6 months of age with growth failure or faltering, which could be author defined in different ways, who are experiencing difficulties with breast milk intake. The interventions of interest are management of difficulties with breastfeeding or lactation, supplementary suckling, or other interventions aimed at increasing breast milk intake. The comparators could be none of the above interventions and or the different interventions compared to each other. So there are multiple approaches to actually analyzing these data. And lastly, the outcomes here, which were prioritized by the GDG, include breastfeeding indicators and intake, anthropometric outcomes, mortality, and morbidity. And just adding another level of complexity to these questions is we're having each of the review teams also look at several different subgroups that might be important to tease apart. So some examples here are whether the infant has been exposed to HIV, whether or not they have comorbidities, as well as different phases of treatment. So I'm now just going to give you an example of one of the prognostic questions. So this is really aimed at determining the criteria for different phases of treatment for wasting and or edema in this case. So for example, what might the anthropometric, clinical, or other criteria be for initiating treatment in an outpatient setting, for referral to treatment in an inpatient setting, for transfer to outpatient or community treatment, and then lastly, for discharge from outpatient or community treatment. As I said before, there are also many other types of evidence in addition to these quantitative data. So for example, the values and preferences, again, to reiterate, that is on the outcomes that are being looked at within all of the quantitative questions. We've also broken down the remainder of the reviews on the other domains into ways that we think make sense to look at the evidence efficiently. So for example, looking at treatment decisions different clinical and nutritional interventions across the effectiveness review questions, as well as community and population interventions, which largely relate to the prevention aspect of the guideline. So in terms of our progress, as I said before, we have a total of 23 systematic reviews underway. In addition to this, there's also a risk stratification analysis that's ongoing in parallel. One of the systematic reviews actually focuses on looking at population or community level factors that might predict risk of wasting. We also have an individual patient data meta-analysis of child risk that's ongoing and being led by the Department of Maternal, Newborn, Child, and Adolescent Health at WHO. In terms of our next steps, we're planning to have a minimum of 3 upcoming GDG meetings through until March 2022. And the purpose of these meetings is for GDG members to make specific recommendations based on the evidence to decision framework that I showed you earlier. Following this, we will release a guideline that includes all 16 of these recommendations. And I'm now going to pass it on to my colleague, Kirrily.
Hello, everybody, and thank you so much, Allison. I always find that presentation very helpful, even if I'm part of this process, to keep track of what we're doing. So, next slide, please. I just want to go back again. There's a lot of figures that you've seen quickly, but I just want to go back over these. We have 16 quantitative PICO questions. We have 4 qualitative PICO questions. We have 3 resource use and cost effectiveness PICO questions. We have 23 systematic reviews underway. These wasting guidelines are covering very broad topics. We have community level, population targeted prevention interventions, all the way to fluid management for a moderate child with severe dehydration. So very broad. It's a big process, and it should be. It should be. We have so much need for guidance. We have recommendations, which we need to look at whether or not they need to be updated in 2013. But we also have issues that really haven't been updated since the 1999 manual. So it is a heavy process, but it has to be heavy. It needs to be heavy so that there's this rigor which is brought to it to make sure that we really come out with the best recommendations out of this. Now, before I joined WHO, there were times when I thought things weren't maybe going as fast as I thought they should be. Now I'm in WHO and I see the process, and I see, for example, 23 systematic review, clinical review teams full of human beings working as hard as they can, but of course there are delays. And if one review fits into another, so I'm not saying this is a cop-out, but I'm saying this to explain this is a very large process, but we want to make sure that we take the time to do this right to make sure that we get the best recommendations. Next slide, please. So there are 2 questions that we want to try and answer today. So I'm going to try and answer the first one, which is how do the PICO questions relate to broader topics? And then Tram from UNICEF is going to come and talk about how we're going to translate these recommendations into practice. So for the question that I'm going to cover, when I say how do these PICO questions relate to broader topics, what I mean by this is you may have looked at some of the PICO questions that are now on childwasting.org website. They've been around in other domains, but you should be able to find them all there now. And you may think, well, that doesn't seem to cover this or that. But what the GDG have done is really try and construct these questions so that actually they end up covering quite a few different topics and that a lot of them are interlinked. That's the other thing I would say about this. We have a GDG, a Guideline Development Group, which is incredibly broad with incredibly ranging expertise. And honestly, I feel we have the right people in the room to answer so many of these questions and to try and come up with the best recommendations. So that's how I'm going to go through and show through the different areas of focus which PICO questions relate to, and then which are some of the broader topics. Let me give you an example. Simplified approaches. I know this is a topic that many people are very interested in. So you'll see that term isn't used in these PICO questions, but we do have PICO questions which will speak to different aspects of those simplified approaches and some of the questions that we're trying to answer. Next slide, please. So I'm going to take you through the main areas of focus that Allison's already talked about and try and show and highlight which PICO questions relate to what. Next slide, please. So this isn't necessarily an area of focus, and it's something that Allison's talked about, but I just want to take a few minutes to talk about it again, because I know that this is an area that so many of us have really, really grappled with. And so what we're trying to really do now is look at what is the evidence that will help us come up with criteria that really inform that decision to initiate treatment in an outpatient or community setting, our admission criteria. What is going to make us refer that child to an inpatient? What is going to make us refer that child to or back to an outpatient? When are we going to discharge these children from nutrition programs? And then even further, post-discharge interventions. Which children really would benefit from post-discharge interventions? And what are the effectiveness of those post-discharge interventions? And again, don't forget that this systematic review is looking at all the published evidence that we have on this. And alongside of it, we have the risk stratification, which is going down to patient level and aggregate databases to really try and identify what are those things that tell us that these children are most at risk of mortality and of serious morbidity. And so for sure, we're going to be looking at anthropometrics, but we will be looking at other aspects as well. And when we talk about all of that in terms of what are the most effective, don't forget, we're also bringing in these qualitative domains. So that means that when we think about, well, this child needs to be referred to hospital, we also have to bring in all these aspects of what is the most acceptable recommendation, or what is the most feasible, what is the most cost effective. So we're really trying to bring all of that in to help the GDG then come up with the best recommendations. And essentially what we're coming down to is who needs what and where. And what this really speaks to so much is how do we make these hard decisions with limited resources? And that's the recommendations that we're really trying to come up with. And of course, as ever with global guidelines, we know that these will often be and should be adapted to context in each country. Next slide, please. So as Allison mentioned, growth faltering failure in infants less than 6 months. This is a big topic for us. And there are 8 PICO questions covering infants. Okay, so that's half of the PICO questions. Now, the focus on this has really been brought to our attention by a lot of the work that's been done by the MAMI group. MAMI being the management of small and nutritionally at-risk infants and their mothers. Just like to put a little advert for the webinar that will be happening tomorrow on co-creation of evidence for the MAMI movement. So what the MAMI movement and people who've been involved in this have really tried to show us that these group of infants, they need intervention earlier for them and for their mothers. If you think about how an infant with a weight for length of less than -3 in terms of where they are on that bell-shaped curve, they're off the curve. You can barely see them. These are really ill infants. What we're trying to do is come to those infants sooner. So with this more broad term of growth faltering / failure, we're trying to capture those infants. Now, you'll see we still have this /failure / faltering because we haven't finalized what terminology we're going to use. So there's been these terminologies around for a while: failure to thrive, growth failure. The sort of problem we have a little bit with this term is it sounds like it's the deed is done. With faltering, we feel a little bit more like we're highlighting a process that we want to intervene in and try and change for the positive. So the important things we're going to be talking about, as Allison highlighted, is breastfeeding interventions. How do we improve breastfeeding for mothers and improve breast milk intake for infants? And so again, we look at what is the evidence for the most effective interventions, but again, taking in mind, but what is also the most acceptable, the most feasible, the most cost effective. And it's all of that the GG have to bring together for these recommendations. The other thing that we're going to be looking at is then this question that I know many of you here will have struggled with, working in stabilization centers and pediatric inpatient wards, is if and when do we have to give supplemental milk to infants who are still breastfeeding? It's a difficult question for sure. And that's why we're really trying to come up with recommendations that are useful. And if and when you have to give that milk, what milk? Are we talking F75, F100 diluted, infant formula? We're really going to try and look at what is the evidence mixed with the qualitative domains to give a good recommendation on that. The next one is routine antibiotics. So the 2013 guidelines was to give routine antibiotics to all infants with severe acute malnutrition. But as you can see, now we're talking about a broader group of infants. Is it still appropriate to give antibiotics to that whole group of infants, bearing in mind harms, benefits, risks, and all the other qualitative domains? Maternal support. We know inherently it makes sense that mothers of infants with growth failure or faltering are going to need support, but what support? Again, what is the most effective in terms of nutritional maternal support, nutritional counseling, in terms of mental health interventions? What is the most effective? What is going to give us the best outcome for these mothers? Next slide, please. So as Allison mentioned, moderate wasting, I think we can all admit, has been a massive gap in the normative guidance in this area. And we're really trying to address that. Again, there are half of the PICO questions take into account children with moderate wasting. So what are we going to be looking at, for example? We're going to be looking at which of these children need certain interventions. Why I'm saying which is that we all know that children with moderate wasting is a very large group of children. We can have a child who's sort of slipped into becoming moderately wasted because of repeated episodes of illness, versus a child who's had a long-term nutrient deficit and has ended up maybe with some of their physiology being almost adapted. So it's a huge group of children. What we're trying to work out is which of those children need what. So some of the questions we're going to be looking at is which of those children need specially formulated foods, and specially formulated foods versus non-specially formulated foods. This feeds in then to a more broader question of what is the appropriate dietary treatment in terms of quantity and duration. So you can see already how that will feed into some of the questions that have been coming up about the simplified approaches. We'll also be looking at some really vital topics for moderate, and then we'll talk about it again with severe in terms of identifying children with severe dehydration. We're going to be going back and looking at the new ORS versus Risamal, and we're looking at fluid management for children with severe dehydration and circulatory impairment in this group. These recommendations have not, up until this point, been explicitly stated for children with moderate wasting. Also then, because we are looking at moderate and severe wasting in our question related to community health workers, this means that we are looking at the identification and treatment of children with wasting by community health workers. There's a whole question on that, which I think is really exciting, and I really hope we're going to get some good recommendations out of that. Next slide, please. So severe wasting. Again, for this, there are at least 7 PICO questions, which will be covering this. And one of them we're going to be looking at specifically is about the optimal type and duration of IUTF for children with severe wasting. So again, that will feed into some of the questions that we've been looking into about simplified approaches. And sort of related to that, but also can be separate, is again looking at the identification and treatment of children with severe wasting who up until now in many community level programs have been referred for treatment. But now we're trying to look at what is the evidence to see if we can recommend if community health workers can identify and treat those children in the community. And again, we're also going to be looking back at those really, really tricky topics about fluid management of children with severe wasting. Next slide, please. So finally, prevention of wasting. I think this is one of the most exciting parts of these guidelines, but I also think it's one of the most difficult parts. And we have to work out what can we, within the scope of these guidelines, and within the scope of who we are as WHO, come up with in terms of recommendation for wasting. But we are trying to look at it from many different aspects. So for example, what are the community characteristics that can increase or mitigate your risk of children becoming wasting? What is the effectiveness of targeted versus population-based interventions? So we're looking at all of this, but again, adding in that extra complication, but importance of what is also the most acceptable, feasible, equitable, cost-effective. So we have to look at all these dimensions, pull all of that together for the GDG to then come up with these recommendations. So it's a very broad topic, but very important. Next slide, please. So next, I'm going to hand over to Tram to tell you about how we're going to take all of that and put it into practice. Over to you, Tram.
Thanks. Thank you, Kirrily. Thanks a lot. So for those who don't know me, my name is Tram, and I'm a nutrition specialist working with UNICEF headquarters and focusing on the care for children with wasting. So I'm just going to take a few minutes to walk you through 2 work streams that UNICEF and WHO have together. So we have a joint work plan that was actually officially announced a couple of days ago during the Nutrition for Growth side event on wasting. And as one of the outcomes of that partnership is on operational guidance. And this is also to say that this is very much linked to the UN Global Action Plan for Child Wasting. And the operational guidance work stream that we have together is very much going to look at how this is going to be implemented. How we're going to have the guidelines recommendation from WHO, and we are going to look at the more practical and operational side of it. So there are going to be products that can be WHO derivatives that would be either updated or developed. We would look at UNICEF products as well whenever it's going to be relevant. But I think that what's important is that we are really looking at setting up an advisory group of UN agencies and CSOs to work on this, meaning that it's not just WHO and UNICEF coming up with what's going to be needed, but we really want to make them practical, have feedback from the countries, from the regions, identifying what are the gaps and how we are going to fill them. Next slide, please. So still under the operational guidance, the idea is also to cover any aspect that might not be part of the recommendations. I saw a comment on the chat box on psychomotor stimulation, for example. I believe it's not going to be part of the recommendation, but that's a topic that we could include in the operational guidance. And that's how the consultation with the different stakeholders in the countries is going to be important. So we can build on the work that has already been done by many organizations and making sure that we get further operational guidance on that. On the different products, we are talking about manuals, for example, training tools, clinical decision-making tools, or any other products that we are currently developing a list with Kirrily and with WHO to make sure that it will respond to the questions from different audiences. And you see here, we have the policymaker level, we have the programmers level, and the healthcare workers. And then, as I mentioned, we're also looking at updating products. Using those wasting guideline recommendations. So here you have also a list of, for example, MCare app, the pocketbook, or IMCI components related to wasting. So this is one of our work stream on the operational guidance, and you're going to hear more about this, I believe. Next slide, please. And so another of our work stream is on research. And again, this is related to the UN Global Action Plan for Child Wasting. And you know that we have a list of research priorities in this one. But we also know that not all the questions are going to be answered in the recommendations that are coming. And we may even have more questions coming up. So again, here we're looking at setting up another group of experts to work with us and keep us on track on what are the research gaps, and what is the research agenda that could be a reference for wasting. So we know that there's already one in place thanks to the Cortazam that was developed a few years ago, and we're looking at updating this. And we are also looking at how we're going to set up a mechanism that is going to help support research and answer all the questions that are going to remain. So again, using what's already in place, the people already in place, the experts that we already know, and having everyone together, working together on this one. Next slide, please. And here is just a small recap. So I think already you mentioned it, and I saw it on the chat box as well. But that's just to say the childwasting.org is really the UN Global Action Plan website. And we're trying to gather all the informations that we have on this one. So you have the very recently released full global action plan, which is the framework on the different summary sheets, the roadmaps for actions of the countries that are part of that. But then importantly, we also have all the tools of the wasting guidelines that are now uploaded as well on this website. So I put that back in the chat box again. Thank you. Over back to you, Kirrily.
Okay, for my final slide, this is a big task. There are many questions, and there may be questions that I personally wish were there and they're not, but we also have to be realistic about what we can cover. We know that we are going to get the point where some of these questions have no evidence attached, and that's when we come to our GDG and say, can we make recommendations on this? How can we make recommendations on this? But we're not going to please everybody. We are going to do our best. I think, honestly, we are covering most of the questions that used to keep me up at night when I was in the field as a doctor working on this. And I think we have the right group of people in the room as GDG to work on this. And I think we also have the right group of people on this webinar today who I know will also, many people will feed into the operational guidance that we'll work on. So I think it's going to be a big joint effort. And I invite you all to participate, and we will be releasing ways that you can as we go along the process. So thank you so much for listening today and for showing up. We're going to open up some questions, so I'll pass back to James.
Thank you so much, Kirrily. Thank you, Allison and Tram. really great updates, and we've got some questions coming in. Some have come directly to me, and some have been asked when you registered. So we're going to have a mix of questions. Maybe to start things off, there's a question that's come in the chat. If there's going to be consideration of nutrition during pregnancy to prevent wasting at birth, so touching on the maternal nutrition side, maybe either Allison or Kirrily.
Sure. Yeah, I can tackle that one. So yeah, this is a really important area, particularly for the under 6 month topic area of focus, but also for the prevention side of things. So this will be addressed in question 15, if anyone's referencing the list of questions on prevention interventions that take place in a community and so on. So that definitely is a consideration for that particular question and systematic review.
And then to add to that as well, there is sort of parallel work streams going on about multiple micronutrients again in pregnant women. There were the recommendations that came out in the antenatal guidelines, but they're now also working on operational guidance related to that. And also there's the guidance for the guideline for preterm and low birth weight infants, which will also probably touch on some of those topics. So there's also a parallel process at WHO looking at that. But yes, we agree, very, very important topic.
Thank you. And there was a similar question, but on psychosocial stimulation. And I think, Tram, you touched on that in your presentation, that maybe this is for implementation guidance, but I wonder if any of you wanted to add to that.
And that's not to say that it's not incredibly important. And anybody who knows Allison and I would know that we are big, big advocates of this. But there was lots of discussions about this, and it was kind of almost, do we need a recommendation to do something that everybody knows we should be doing? So that's why really the decision is that it would be in the operational guidance. And it also means that we can try and make it as useful and practical. And we're not going to be reinventing the wheel. We are going to be working with organizations who've already done a lot of work on this. So we want to make a big focus on this. We don't want it to be kind of the last section in the last chapter. There is a big focus on that. Anything else, Allison, you want to add?
No, I think that sums it up well.
Thank you all. Is there already an unanswered questions list? Tram or Kirrily, maybe, are you collating these?
Yes, there is an unanswered question list. And again, some of it we did already try and feed directly into the operational guidance. And some of it we are kind of keeping very much not in our drawer, but stuck on our screens, and how we're going to address that and how we're going to look at that. And we will have to work out different mechanisms and different ways.
Thank you. So Kirrily, you were mentioning, well, actually all of you were mentioning how severe wasting and moderate wasting is going to be looked at. Particularly moderate wasting, where there are still so many questions. Do you know at this stage whether the guidelines will combine severe and moderate wasting into the same guideline, or will there likely be separate guidelines for both?
So we are intending to cover moderate and severe wasting and infants with growth, faltering, failing in these guidelines on the prevention and treatment of wasting. So there may be recommendations which are more specifically related to one another, but they will all be included in this guideline.
Thank you. Great. So I've got a question that's come directly in, and it's about the risk stratification process. So you mentioned there's a lot of parallel initiatives going on at WHO, and the risk stratification process is one of those. And the question is, how does that process fit into the guideline development process? And I also know there's probably several of you in the room who might be involved in both. So feel free to put up your hand if you want to add. Maybe we can start with Kirrily.
It's such a big, big topic that, yeah, if anybody else wants to talk about, they're welcome. I think, as I tried to sort of say it, so we have questions. PICO questions 1 and 2, which are really about risk stratification in some ways, are really trying to look at it. What is the published evidence? So what is the current evidence that we have to look at these questions? And then the parallel process is the risk stratification, which is being led by Nigel Rollins, and they're really trying then to speak to different groups who have different data sets and work out how we can look at all of that to try and come up with the real, trying to work out who are the children most at risk and what are those criteria. I'm like a terrible stats and research person, so that's probably a really simplified way of explaining it. I don't know, Alison, if you can make it sound more clever, which it really is.
Yeah, I think one of the objectives of this, so it's essentially an individual patient data meta-analysis, so compiling several different data sets and looking at mortality as a main outcome and several different predictors of mortality. In terms of how it'll feed into the guideline, I think, Kirrily, you've also summed it up well, but there's potential that for some of these systematic reviews, we might have author teams go back and do additional subgroup analyses based on different risk factors that are identified in that process.
Thanks, Alison. Marie, you had your hand up. Would you like to add anything? Feel free.
Yes, well, just listening to this this question, and I'm involved in the risk stratification for MENA and also an observer on the wasting guideline, and they really are so complementary. And Nigel Rollins actually presented on the risk stratification in the scoping consultation way back in December. I think it was 2020. So I'm just thinking there's going to be outputs coming out of the risk stratification over the coming months in a stepwise, through November, December, and towards the end of January. And Alison, just looking at the timeline you shared, where there will be consultations coming out through to March 2022, I was wondering, is there a way of having some of the evidence, or at least a direction of travel in the risk stratification that could actually feed directly into the wasting guideline, because they're happening in tandem and in parallel, but can we make them more that they complement? And I know WHO, the teams talk together, but I'm just wondering if even on a practical level, if there was to be a mapping out of what systematic reviews and consultations will happen and their timeframes, and when are the outputs of the risk stratification, and seeing how we kind of practically connect, because I think it would be so helpful to have that emerging evidence feeding into the GDG and their decision making, because as you say, Alison and Kirrily, it's about, they're looking at in the risk stratification, looking at what are the predictors of outcomes, and you've got predictive questions, and that is so fundamental to the wasting guideline. It'd be just so I think maybe it's how we practically connect and feed in a real-time way to really maximize on this great effort that's happening at WHO on both fronts.
Yeah, I couldn't agree with you more there, that there really needs to be a marrying of these two processes. And this is something we're discussing amongst our team, and also trying to link up the authors doing the prognostic questions 1 and 2 with the group doing the risk stratification work, to make sure that we kind of come to recommendations that align both processes. So that's something we're discussing. In terms of the timeline with the GDG meetings, we are trying to have some earlier meetings on questions that might not have as much evidence as other questions. So just a couple of studies have been done on a specific topic area, which might make it very challenging to then incorporate risk or additional subgroup analyses. So we are kind of taking that in mind as we're planning the process, but it's really a work in progress as the reviews evolve and as this additional analysis evolves.
Yeah, so much of it is timing. It's trying to, because at one point we were thinking, should we wait for the systematic reviews until the risk strategy, and it sort of seems that one kind of goes ahead and then the other one. So really it is timing, and we just really we're trying our best to see if we can kind of put it all together. And honestly, if we get, one's done, but then the other one's finished and it shows things that we need to adapt, then we all have to adapt. We will just have to do that, because it's really important that we get this right.
Thank you. And that actually leads on to the next question I have, and it's on timelines. Actually, I think there were a few people that joined midway through your presentation, Allison. So, just a request: could you do a quick recap of the timeline for the guidelines, and then Tram, I'll ask you to come in on timeline for the guidance and whether that is a parallel process, or when will the guidance process start? So, starting with you, Allison.
Sure. So we have 23 systematic reviews that are underway. So 16 are quantitative reviews that will lead into recommendations. And then these are supported by qualitative reviews and resource use reviews. So it's quite a large amount of simultaneous reviews going on. Because of the huge number of them, we plan to have a series of GDG meetings where GDG members will be given all the evidence for specific questions that we choose to then make recommendations. So we plan to have at least 3 of those basically between the end of this year and March of 2022. Also, just for context, a previous guideline development process, which had 6 recommendations, took 2 weeks of discussion. So we are really trying to figure out how many questions we can discuss and ensure that people still have the capacity to think through the nuances of these different questions. So although we've planned for a few GDG meetings, there's potential that process might be extended as well.
Thank you. Thanks, Allison. And Tram, maybe could you talk about the timeline for guidance? And as you do that, there's a question on the guidance as well, whether NGOs and other partners will be invited to contribute.
Yes, so that's really what we're looking at. I'll turn that to Kirrily about the timeline, because I understand that's yesterday, but then we're going to take a bit more time. It's actually between her and I think we are ready to launch it soon. We're looking at the platform at the moment and confirming that. And obviously the idea when I was talking about UN agencies and CSOs, that's really like using the groups that are already in place, like the Wasting Working Group under the GNC Technical Alliance, for example, but other groups potentially at regional level or country level, since we want that country level representation and regional representation. I don't have a clear timeline in mind, Kirrily, but I know that we want to push this one quite fast, so it's going to come.
Yeah.
Right.
I mean, I would say it's already started. I mean, that was the whole thing. We were never going to wait until the guidelines were finished and then start the operational guidance, because it's too late. So in some ways, what we're doing is already starting up as Tram said, the process of going to people. And I just realized as you were saying CSO, because it's a term I only recently learned, civil society organizations, and that does include a lot of NGOs and other groups. So so we've already started that, and in some ways for lots of these things, we can already start doing our kind of clinical decision-making tree, and then it's probably at the last minute we're going to add in how many mils per kilo, so a lot of this stuff we will already start, and some of the products like the manual and training tools, there's a lot of work that's already there. It's just those final detailed recommendations will have to go in. But so we have products that's already started, but we also want to make sure that I know in my head what I think we need, but we also want to know from other people if we're creating a need. And that's why we also speak to the UN agencies, country offices, regional offices, and we speak to them and say, what have you been getting demands for? We speak to GNC, what are you getting demands for? Health cluster also, what have you been getting demands for in terms of guidance products? And so then we're trying to bring that together. Timeline wise, I am not going to commit to anything. No, I mean, it's going to be, it's not going to be tomorrow. It's not going to take a year, but it's going to be probably somewhere in between. So I know that's not as useful a comment as I like to. I think as we get towards, we're getting more clear where we are in the guidelines process, we will have a better idea, but there won't be far behind the guidelines.
Thanks, Kirrily. Brilliant. So I'm just going to go back to something, Allison, you were saying about just the sheer volume of systematic reviews underway and how much time it takes to have the consultation and come to as near consensus as possible. And there's a question that is around these consultations are going to be online rather than face-to-face. And do you foresee any challenges in giving enough airtime for people to be able to really discuss what they want to and make sure contentious issues have been addressed? Do you have any ideas how you'll manage that?
Yeah, I think we've been really limited by these virtual meetings. I think it limits even the kind of organic discussions that take place even outside of the room amongst GDG members. So we are actually hoping that we can have a meeting in person in March. That might be ambitious, but we're doing our best to try and make something like that happen. We're also thinking of other strategies for the meetings that we can't have in person, such as, for example, limiting them to a couple hours a day, and perhaps having a series of meetings that aren't across consecutive days, but rather are separated by a week period that gives GDG members the time to really process the information and go back to the reviews. But we're still kind of thinking through the best approach in that sense. Kirrily, if you have anything to add, please jump in.
Saying that, I mean, yes, it's limited. I do think, though, that everybody since COVID has had to get used to making some of these big decisions in virtual meetings. And I have to say, from some of the workshop that we did refining the PICO questions, people are engaged. There's lots of very heated debates that go on, and I think some of it is just necessity. And we really would love to have in-person meeting, as Allison says, because of the richness. But we also know that if one person can't come due to, restrictions, then nobody's going to come, because it's got to be, an equitable process. So that's our dream. But we know that also COVID has made all of us become much better and more efficient virtual meeting members, really.
Thank you. Brilliant. We've had a couple of questions come in on specific topics that may or may not be covered by the guidelines. One of those is on are infants and children who don't have a mother as a caregiver to orphans, are they being considered in the new guidelines? Or do you think this will be a guidance issue?
No, I think there will be, it's a really tricky one. It's the same way that we keep talking about the mothers, and I think in some ways we end up doing a bit shorthand, even as we kind of end up doing in the MAMI, because Conte's saying mothers stroke primary caregiver, mothers stroke primary caregiver. But, we're not ignoring this fact. And all of us who've seen so many, grandmas looking after these babies and different family members, we're completely aware that it's often a family effort. It's not always just the mother. And very sadly, if, the mother's not around, that you have to look at the infants. So there is very much a focus on infants. What we're trying to do is kind of like, there's been so much focus in the past of just on infants, whether or not they're with their mother breastfed or not. And so we are trying to talk more and bring this kind of MAMI approach in of looking at the mother and infant together. But that's not to say that there aren't going to be recommendations which would absolutely cover infants whose primary caregiver is not their mother.
Yeah, and just one other point to add, within questions 1 and 2, in terms of the criteria or potential prognostic factors, we have actually added that as one of the criterion to look at, is whether the infant has a mother around or not. So I'm not sure whether there will be actually much evidence on that, but it is something that we've asked review teams to look into.
Great, thank you. Thank you everyone, by the way, for all these fantastic questions. Just going to continue for another 5 minutes or so, but do keep them coming in, because even if we can't answer them, we will collate them and pass them on to WHO. There was, well, with COP26, happening, and climate change in the news. How is climate change and its relationship with exacerbating wasting being addressed? Is that going to be part of the prevention, or?
I saw that come up in the chat. Thanks, Iris. Thanks for that.
You're primed.
It's a really, really, really good question. Tram and Allison chime in. I think that in the prevention aspects, it can't help but come in. I think that will be when we're looking at the community characteristics. And I should imagine in risk stratification it will come in. But yeah, really, really hard, but also really topical. So I think it's something that we kind of have a whole bunch of things there. again, like on my screen of all the things like disabled children, climate change. So all these things that we need to not forget, all those kids, those groups, these factors that we need to try and bring in. And I'm not going to say that we're managed to do everything. And we also have to keep reminding ourselves of our scope as WHO and what we're in charge of and kind of what we're not in charge of. But definitely something that we are trying to keep in there. I don't know if UNICEF can give a better answer.
No, I think you're right, but I can see this coming up as well in the ops guidance discussion. So I think that would be interesting to see what's already been done by some of the partners and organizations, and what can be what we can build on, really, because it comes up from our side as well. We don't have the specific focus, I guess, that the question implies, but I think, yeah, that would be interesting to bring that up actually for discussion.
Thanks, Tram. Brilliant. Got a couple more questions that have come in. One is on moderate wasting. Will there be food-based recommendations to low-risk children who don't need specially formulated products?
So we have two questions that are focused on dietary management of moderate wasting. So questions 7 and 8, and those really look at if and when children with moderate wasting might need a specially formulated food or other food interventions or other types of interventions that are not food-based. So that is something that's being looked at very closely. And question 8 is about the type, duration, and quantity of dietary interventions that these children need. So that is being looked at quite extensively.
And again, we all know that, WHO is global guidelines, and that, of course, especially when something's related to food, it is going to need to be adapted to context, and, right down to very sort of district level, it could be even as well as country level. So we know that there's also that important element to it.
Thank you. Great. There was a specific question on children with disabilities, but I think, Kirrily, you mentioned that this is very much on WHO's agenda.
Yeah, it really is. And I think that's often because, it's something that I've had the experience, I'm sure many people here have had as well, of, I've had terrible sort of questions of like, should we even admit these children because there's nothing we can do for them? Yes, admit them, let's try everything we can for them, but at the same time being really clear about our limits of care and what we can do in different contexts. But there's so much we can do, and then there's great organizations already working on this, like MATES, and so there is things that we can bring in. Absolutely, operational guidance wise, these are things that we can really try and push for, because these are kids that we really mustn't forget. And I think, we need to, I don't know what the data is, but I would say from my own experience, I think it's a kind of small but significant proportion of children who are there and spend especially a long time in inpatient and nutrition programs in general are children who have mental or physical disabilities.
Thank you, Kirrily. Maybe one final question before I wrap up, because time has flown. What's the follow-up to this webinar going to be? So the way of getting updates out, that's a question that's come in, and thankfully we've got the launch of the website you mentioned. But
yes, so we will be, so we'll be, as things come up, like even today, the recording from today will be going on the childhealth.org website into the tab on normative guidance, and as things come up, we're going to be putting it on that website, and at some point maybe ENN will twist our arm into doing another webinar. So that's all right. We want to make this a really transparent process. We want to keep updating people, and of course, as soon as we get really going with the operational guidance, we're coming to ask you all to help us a lot more. So yeah, we will just keep the main point of focus will be the childhealth.org website for now, with all the updates we possibly can. And actually everything that's on there now is things that were already in the public domain. It's just they were sort of in different places. So what we really just tried to do is put them all together in one site.
That'll help so much. And thank you. I think I should wrap up here and to say a few thank yous. So Allison, Kirrily, and Tram, really huge thanks for making the time today and updating us all.
Thank you.
It's been so helpful, and thank you to everyone who's asked questions and all of you who have showed up for your interest and engagement. And as I've said, if we haven't got to your question in the chat, we'll compile any outstanding ones and pass them on to Kirrily, Tram and Allison.
And we will really try and work out a way of looking at those and seeing how we can communicate back.
Thank you. And I should say a big thanks to the teams at the Eleanor Crook Foundation and Irish Aid. They've supported us to put on this webinar, so thank you very much. If you've got spare 30 seconds, please take the time to fill out a few questions or feedback to help us improve these types of sessions going forwards. There's a link in the chat. And just to reiterate, we will make the recording of the session available to you through the child wasting website and no doubt on ENN as well. So all that remains to be said is a huge thank you and have a good rest of your day.
Thanks, everybody. Thanks for coming.
Bye, everyone.
Thank you.